Welcome everyone. Welcome to today's Learning Summit, an opportunity to see and explore how ICSs can tackle health inequalities for people with learning disabilities by working in partnership with people across all sectors, NHS, local authorities, social care providers and the voluntary sector. This is the sixth event of a jointly convened ICS Learning Network between NHS England and Care Provider Alliance. It really aims to deepen relationships and collaboration between the health and social care sector and promoting innovation and good practice. We have an exciting agenda, but first my name is Tom Cahill. I'm the National Director for Learning Disability and Autism. And you're going to hear a little bit from me throughout the agenda, and I'm co-chairing with my partner in crime, Clive Parry. Clive is Director of Association for Real Change, and you'll hear a little bit from Clive in a while. We've got an exciting agenda, so I'll just take you through that fairly quickly, if that's okay. Firstly, we're going to hear from David Sheardon about his experience, but he's with Helen. He's with Helen from Ashford, from Operations Manager at Linkage, and we'll hear about their experience and particularly a reflection on David's experience navigating local systems. And then delighted to have colleagues from West Midlands Self-Advocacy Network, Bev, Stuart, Matt, Amelia. We'll hear their stories about co-production in that area. We're also here then from local systems about what they're doing in spotlighting learning disabilities and health inequalities for autistic people in Sussex ICS. Vicky, delighted you're joining us, Idel. And then we'll hear from Paul McKay, who's Chief Executive of the Wilf Ward Family Trust, and we'll hear a little bit more from him. And then we will move into a panel discussion, an opportunity to pick up some of the questions that you've been setting out through the day. It's myself, Hazel Summers, who's Director of Improvement and Partners of Care at the LGA, and David Holmes, Chairman of Peak 15 and Support. And then Clive and I will close the event. So a lot to pack into an hour and a half. We're really looking forward to taking you through this and hearing about the good practice. I'm just going to give you a quick NHSE perspective on health inequalities and learning disability and autism, and given my role, this is my main priority. We know the statistics. They're well known to us. Life expectancy 20 years less than the average person, and then if you ever come from an ethnicity and you've got a learning disability, life expectancy around 33 years. Causes of death, we know leader tells us 42% of them are avoidable. We need to remember avoidable deaths. Health outcomes, poor health outcomes, obesity, diabetes. And we know that life chances for people who are autistic or people who are learning disability, have a learning disability, employment, friends, connections, all of that are reduced. What we know is about 1.5 million in the country have got a learning disability, and Nuffield Trust said there's about 1.2 million autistic people. And we continue to hear horror stories, and I think there's a message today that I'd like to start to convey, is that for every horror story, which is really, really devastating and really wrong, we're also hearing some really, really good practice. And there is a lot of good practice up and down the country in schools, in primary care, in acute care, whether we're keeping people out of hospital, and it's really, really important that we embrace that good practice, improving access and support to primary care. We're hearing acute care really making in hospitals, helping with reasonable adjustments, even going through waiting lists to make sure that people with a learning disability or autistic, if they're at risk, trying to move them off those waiting lists. Keeping people out of hospital, really important. We've invested 121 million over the last 3 years to try and help create infrastructure that keeps people out in hospital. An example of that would be the key workers. And then we're continuing to discharge people at home. And I'll just remind you very quickly, I know a story of Katie, who came in when she was 16 into hospital and left when she was 36. Kelly, she spent 28 years in hospital and she's at home in her own home now. And John, 21 years and is now discharged. And what I say about those is, one, God, why are people in hospital for so long? This has got to be so wrong. But equally on the other side, people don't give up. People do have hope. In terms of the NHSE perspective, our ambitions are longer, healthier, happier lives. And we've got two main priorities. First one is those that are in hospital who shouldn't be. Let's get those people home, get them to a better place, and let's prevent people going into hospital when they don't need to. So we've got the 121 million investment that I talked about. We've established community teams. You've got key workers for young people, which is really doing well. And then on the other side, our real ambitions around improving health outcomes and the length people live and the well-being of their well-being. So this is built around the annual health checks, but not just annual health checks. We've got the digital flag coming, which is about reasonable adjustments. And we've also got learning from deaths, and it's really important that we use Leader as a catalyst of change. And I'll say two things that for me, I've been doing this for 2 years. There's no one thing that will sort all of this. There's many, many little things that will. And I'll say in final, before I pass to Clive, it is doable. We can make that difference. And it is about leadership and about willing to go that extra mile. So I'll talk more about the NHS a little bit later, but Clive, I'll hand over to you now.
Well, thanks, Tom, and welcome everybody to the Learning Network. My name is Clive Parry. I'm the England Director for ARC. ARC is the Association for Real Change. We're a membership body. We have about 100 organisations that are members of ARC, and they all provide services to people with a learning disability and autistic people. You'll notice that the logo on the bottom of the slide there is actually the CPA rather than ARC. The CPA is in effect the umbrella body for umbrella bodies, is how it was described to me. And so ARC is a member of the CPA, which is an organisation that supports membership and trade associations. So I'm here today, excuse me, to give the national context in terms of the provider perspective. And I think the thing to emphasise, and picking up on some of the comments Tom's made about health inequalities, is that the majority of our members are actually funded by local authorities. And as we all know, those organisations, those authorities have experienced unprecedented budgetary cuts in recent years. And the truth is that many learning disability and autism services are now operating in a financially unsustainable state. And there are real challenges around this, particularly in relation to helping people with those health inequalities and providing person-centred care. And that is probably why we're seeing in the delegate questions that we received ahead of the learning event today is the questions focusing on health checks and making sure that those take place. These are the annual health checks that every person with a learning disability should undergo. Working in partnership has featured quite significantly ahead of the session today, and also the skills of staff and the experience of supported people and their families, and all of those we'll be touching on today. So before we, I'd like to now just move on to our first speaker. So it's just to let you know that David actually is not able to join us today. We were going to be joined by David, who is supported by Helen at ARC member linkage. Unfortunately, David isn't well today, so we'd like to send him our best wishes, Helen, and to thank him for being willing to join us today. But Helen is actually going to join us now and share with us some of the things that David was going to talk about. So this was David was going to talk about his experiences of accessing health systems and illustrating some of those health inequalities. Can I hand over to you, please, Helen?
You may indeed, yes, thank you very much. So hi everyone, I'm Helen Ashford. I'm Operations Manager at Linkage. We are a Lincolnshire-based charity supporting adults with learning disabilities and autism. So David is a person we support who has had experiences of NHS services, which we've supported him with. So the bits that David was going to talk to you about today, I've split into three sort of sections. So firstly, he was going to talk to you about the work that he does with Lincoln Hospital. He's actually appointed as an expert by experience. So he trains with the doctors and nurses, educating about the Oliver McGowan training specifically, talking to the teams about how locally services could be better, from his experiences as a person accessing those services, from the main focus being around communication. He feels very strongly about being respected and being listened to, and his voice being heard and not other people speaking for or about him, because he's able to self-advocate. We then had a specific situation that David found himself in due to a health condition he has, where he had a paramedic visit himself in his home, and He explained to the paramedic his symptoms and his diagnosed conditions, and was advised by the paramedic that he couldn't see that information. And David's interpretation of that was that he wasn't believed. We discussed this at length. He went to see his GP following the visit from the paramedic as well. And it's because we understand now that the paramedics don't see all of the records that the GP see. And again, it's different with the hospital services as well. So he wanted to talk about why can't everybody see all of those records to see everything about his needs, rather than him having to explain those things and perhaps not always being understood or being listened to. And it comes back to that being respected, being able to self-advocate. So that was that situation. And then the other piece that David wanted to talk about was about annual health checks and a hospital passport. So he has obviously an annual health check, and he has a booklet that goes alongside that details his needs, what services he's accessing, but it's done in an easy read format so that he has a good understanding of that. Alongside the annual health check book, he also has an All About Me hospital passport. So should he experience a situation whereby it's necessary for him to go into hospital or to have a visit to the hospital, he's able to provide that booklet which details how he communicates, his likes and dislikes, what he might need in terms of environmental factors while he's visiting the hospital as well. But one thing we've identified is actually, why couldn't those two things be combined, those documents, and could they be accessed electronically by medical professionals as well, so that he's not having to carry that information around with him when he's accessing those different services.
Thank you, Helen. Some really powerful stories there from David, and it sounds to me as though David's somebody who's quite good at speaking up for himself and obviously able to advocate for himself, which isn't the case for everybody, of course. And so I think there's some really important points there about treating people with respect and obviously treating people's data and information with the same respect. And if somebody would say to me, I'm not allowed to see my medical data, I'd be quite concerned about that and struggle to understand it. And then some really important points there, Helen, about duplication of effort, isn't it? And duplication of records, which can lead to all kinds of challenges, can't it?
Yeah, it's that repetition that David felt very strongly about.
So an invitation from David there to do things a little bit more efficiently, actually, in some ways. So thank you very much, Helen, for joining us today. And as I say, do please give David our best wishes and thank him for being willing to come along and talk to us today.
I will do, thank you.
So we're now going to hear from Bev, Rose, Caroline and Amelia at the West Midlands Self-Advocacy Network, and they're going to share their experience of creating a co-developed health check product. Can I hand over to the West Midlands Self-Advocacy Network?
Thank you very much. We're going to go a brief talk about our survey. I'm going to hand over to Matt, who was our first speaker.
Hello, I'm Matt.
Hi, Matt.
Hello. We have worked with IDAS to look into how people with learning disability and autism interact with health services. We were a good fit for this research as we have a deep research into our communities. Between us and IDAS, we came up with 15 key questions for the survey and created an easy read questionnaire. We surveyed across the wide West Midlands area in rural and urban settings, covering Worcestershire, Herefordshire, Shropshire and the West Midlands, including Birmingham, Dudley, Solihull, Walsall and others. When we have finished our survey, we had completed 537 questionnaires.
Oh, I see. So I'm muted. Can you hear us?
We can, yes.
We can.
Yes,
Okay.
we can hear you well, Matt.
It's
Carry on.
Sorry, my apologies. Teams are saying we're muted when we're clearly not.
Oh no, we can hear you, Matt.
Okay,
That's
keep going,
okay.
Matt, sorry.
So we have completed 537 questionnaires. We did this by doing face-to-face interviews, emails, and telephone conversations. Our age range was anyone from 18 to the over 65s. As it turned out, the majority of people were in the 31-50 age group. And we'd like to hand over to Amelia, please.
Thank you, Matt.
That's okay.
Okay.
Do you want to go ahead, Amelia?
Everyone, I was on mute.
No worries.
Sorry.
After we completed the questionnaires, we entered all the data into SurveyMonkey so we could analyse the results. We then worked with a video production company who created a documentary that recorded how we went about it. This section of the video will give you a better idea.
We just want to be listened to. We just want to be listened to and be respected as people. We have a disability, but just speak to us, listen to us, and try and understand we're the patients.
We started off in a different project, really trying to find out more about how to identify signs that people were becoming ill.
And that's basically about trying to equip support workers, people who with learning disabilities who live in their own homes, to really be able to understand and act on when the person they're supporting becomes unwell.
The main part of this project was about looking at something that the health people call soft signs.
Soft signs are those subtle, soft changes in somebody's physical behaviour or emotional behaviour that start to indicate that there's a change from their norm.
You start to get poorly, and if somebody does something straight away, gives you the right tablet or gets you to the doctor on time, then it gets better. But if that doesn't happen and people don't notice, and you start to get more poorly, then by the time you get to see the doctor, they have to do a lot more things, and it can be more serious.
And what we felt really made sense was to then have a parallel piece of work that actually asked people with learning disabilities themselves about their experiences of what happens when they don't feel well.
I think some people don't always understand just how difficult it can be for somebody with autism and learning disabilities, you know, just to ask for help sometimes, especially if they are, you know, if they can't talk or anything, you know, if they are non-verbal.
The getting help with my health is important because health is so important.
There's far too many people that, you know, that are being neglected, I suppose, in a way, and you know, their health is, you know, it's not the greatest, is it?
Our involvement with the West Midlands Self-Advocacy Network came about because we very much wanted to talk to people with learning disabilities about their experiences of what works well for them in terms of using the health service and what areas needed improvement.
And what we could do to try and help people be able to help themselves, look after themselves more, or for people who are supporting them to do the same.
And they asked us whether we wanted to be included in the project and work alongside them, and we was all really keen to get involved, really, because we all sort of agree it is a very important project.
And we had a few ideas about questions that people might want to ask about their health. and we started chatting with them. And actually then they came up with loads more, much better ideas.
We realised that some of those questions were similar to a project that we were going to do in March 2020. And that was a project that looked at the way guys with learning disabilities and autism, how they're treated at their local health centre or doctors.
Chris and I spent a bit of time looking at their questions, asking can we put one or two other bits in.
About how they get support for their health, the really big issues for them, the problems that they've had in the past.
Some of the questions that we were given weren't what we as adults with learning disabilities or people with autism would speak about. We wanted them as though they were not jargon.
Some people can't read, so they tend to go on things better with pictures or images, and they sort of like understand a bit more that way.
And we also wanted them to be as reasonably simple.
So yeah.
I wonder if we've lost sound. I don't know if that's the same for others.
We can hear you.
Yeah.
Can hear you.
Oh, okay. So we've reached the end of the film. So my mistake. Well, thank you, Matt and Amelia. Is there anything you'd like to say about the film?
We're not finished.
There's more to say yet.
Yes.
Carry on, Amelia.
Sorry, apologies for the quality of the video and the sound. Sorry, it kept going in and out. I know there might be some technical issues there. But yeah, just to say, I've just got my last bit to say. So we're still doing our presentation at the minute.
Yes, please do. Please do.
Thank you. The video also included the results of the survey shown as pie charts that made the data much easier to understand. There were several key points in the results, but there was one overriding issue that came about again and again: communication. All patients, not just people with learning disabilities and autism, need good, honest, open, clear and accessible communication between themselves and healthcare professionals they come into contact with. That includes doctors, nurses, physiotherapists and all of other specialists that it takes to run a comprehensive health service. We often tend to shut down when being given news we don't want to hear. So if it is hard to take that news in the first place, the likelihood of good understanding is very low. 60% of the people surveyed said they didn't always understand the doctor or nurse.
Right. Thank you, Amelia. So we selected some of the topics for the survey. As Amelia has already pointed out, communication to one extent to another is essential. There's a need for clear communication because it's equally important to everybody. You know, including when you're dealing with people who have more complex needs, whether they be physical, psychological, or anything else. They may have limited or no speech or limited or no reading. Annual health checks. In our survey, 61% of people were confident that they'd had an annual health check. What about the other 39%? Maybe the doctor wasn't clear about whether they had or had not done an annual health check. If they had, a regular doctor. 65% of people don't get to see the same doctor, which means they have to explain everything over and over again to different people, and doing that can be often more difficult and stressful than the actual consultation itself would otherwise be. A new doctor can sometimes ignore the symptoms and think, oh, this is down to disability, and try to treat that, which doesn't really work very well. When it comes to taking medication, a lot of people said they didn't understand when to take it or what it was for. And a lot of people didn't know what to look for, if there were any other side effects or other adverse effects, and what to do about them. Hospital passports. It was interesting to hear what you said, Helen, about David and the hospital passports, because 71% of people did not know what a hospital passport was. And if they did know, well, they didn't have one. So, you know, going into hospital, the doctors without a hospital passport may not know anything about them, which is another barrier when it's stressful and concerning enough already going into hospital. And 49% of people either didn't know what the Learning Disability Register was, or they weren't on it. And when it comes to time to think, 45% said that they were not given sufficient time to be able to think about what it is they've been told, to consider their answers, or, you know, ask any questions they had. And all too often, that information wasn't actually given to them, but their support staff, as if they weren't there. In the Kidderminster area, at least, I guess, things are looking a little brighter. The local learning disability nurse, she works closely with the experts of experience to better understand their needs, and has access to, talks the language of, and is able to work with local health professionals, which makes what she does more effective. And now I'll hand over to Bev for the last bit. Thank you.
From these conversations, we also found some issues with care vision, so it's worth chatting that through of this at the seminar, and it has been suggested that health and social care don't get the opportunity to understand the challenges faced by each other. Generally, carers only have time to provide the life support, care and keep a person safe. There's very little opportunity for a carer to provide anything over and above this. Even with notice, care providers seem unable to change their schedule to support social events or health appointments, or to fit in with people's meal times or bedtimes. During our survey, we found that people with more complex needs were the hardest to reach. This may be due to the carers we were questioning being time limited already behind schedule. Carers also swap and change a lot. They don't get to know and understand the person they are going caring for. They can't so easily work their self-science. And soft science. Or early symptoms to have any health issues before it develops. Carers need time to slots to enable them to do this. Although AIDAS commissioned us to do this survey in 2022, overall, and from the issues we continue to experience, it seems that not much has really changed. Principles as well. Video.
So there's a very small piece of video now.
Yep, very small piece of video.
I think there's still
Thank you, Bev.
of misunderstanding between doctors and nurses and people with autism and learning disabilities. I think there's still a lot of work really that needs to be done to improve communication, especially with with the most vulnerable of people who perhaps can't really speak up for themselves that well.
I spoke to a gentleman in one of my consultations. He'd not been to the.
So, I think that's it.
Yeah.
Yeah. We think that's the video finished.
Thank you, Rose.
Has
anyone got any questions?
really finished?
Yes, no, you say that. Thank you for listening.
Thank you for listening. Does anybody got any questions?
Well, thank you, Bev. While folk are thinking about any questions they might have, I just want to say thank you to the West Midlands Self-Advocacy Network. There's so much there that it's impossible to get into all of it. But a few things that I thought about whilst you were presenting was just how active everybody is in trying to make things better. So conducting all of this research, you've used technology from the sounds of it as part of that process, and you've done quite a lot to think about people who might need more support to communicate, people who might need a little bit more support to be able to speak up and have their voices heard. So a really powerful description there of what it looks like when people come together to try to support each other and to try to support the improvement of understanding. And I was particularly struck, Bev, by what you said about health and social care not understanding each other, and providers not having enough flexibility to be able to change and support people with health appointments, and perhaps carers changing quite often so that they don't necessarily understand the people they're supporting as well as they might. So some really powerful testimony there, and thank you very much for sharing with us. We will come back to you with some questions at the end. So if you're happy for me to do so, I'm going to move on now to our first system example. We're going to hear from Vicky Baker, who's the Clinical Director, Learning Disability and Neurodevelopmental Services at NHS Sussex Partnership Foundation Trust. Vicky, I have no idea if you've squeezed all of that onto a business card, but I'd be really impressed if you do. We're also going to be joined by Adele Parsons, the Senior Lead Reviewer from the Learning Disability Mortality Review Project. So for anyone who's not familiar with that, this is the project that looks at deaths of people with a learning disability and produces reports every year that talks about health inequalities, the reasons for people passing away, and whether any of those reasons could have been avoided. So the short name for that is LEADER. So it stands for the Learning Disability Mortality Review. Vicky's going to talk to us about the integrated care system in Sussex and how you developed a health inequalities programme, which is informed by the LEADER programme. So I'll hand over to Vicky and Adele if I can.
Thank you very much, and thank you for inviting us. A summary of my title would be that I'm a clinical director, but I guess close to my heart is I'm a speech and language therapist by background, and I've always worked with and for people with learning disabilities. And actually, this is one of the projects or partnerships that I'm most proud of in 30 years working in the NHS. And Adele and I are going to talk to you about this Health Inequalities Project Board that we've got in NHS Sussex. And this I guess we call it a board, but this group came out of the work that we did around COVID. And what we realised within the COVID pandemic is there was so much information coming and so much happening so quickly. We pulled together what we describe as a coalition of the willing. So loads of people that were passionate and cared about people with a learning disability. So people with a learning disability themselves, their family carers, different organisations, comms teams, people like myself in providers, the local authority, a whole range of people we brought together to really try and think about what we needed to do to support people through the pandemic. And then from that, what we realised is we had this really powerful partnership. And so we established this group, and it was interesting that Tom said at the beginning around people going the extra mile. This is something that we developed as a group of people. It wasn't something we were told to do. It was something that came from a group of willing, able people, and it's really gone from strength to strength. And it's something we're very proud of and are very pleased to share with you. So I'm going to talk about how that group operates and who's in it and how it works. And then Adele's going to give you an example from recent practice. If I can have the next slide. So in terms of who we are, and it's a big long list of people, it doesn't look very exciting, but if I give you a flavour, so I chair it and I sit in a provider trust that has 6 community learning disability teams and an inpatient service and a domiciliary care service. We also have the learning disability and autism lead from our ICB colleagues. We have self-advocacy representation, family carer group representation. We have some people who are autistic that attend, and there's a group of autistic people that advise us sitting behind that. We have representations from population and public health. We have people from primary care who lead on annual health checks, and people who are workstream leads in the integrated care board around a range of health related conditions. We have our public involvement team and our comms team. We have somebody, for example, who leads on the web design, so we can try and make our website more accessible. And then we have representation from all of the clinical priority work streams, and the clinical priority work streams won't be any surprise to any of you. They're all the things that we have learnt that make a real, that are some of the key factors contributing to the early and avoidable deaths of people with a learning disability. So that list there shouldn't be new to people here. These are all the reasons that we can try and prevent ill health and prevent early mortality for people with a learning disability. So we have a lead for respiratory pathways, and that's a real focus on reducing community acquired pneumonia. It was really interesting hearing from the West Midlands group around those soft signs. We have a whole programme of work around recognising soft signs. So important that we listen to the people that, obviously people with a learning disability themselves and their family carers, and they notice just the tiniest signs that show that something may not be right for that person. We have a lead for cancer, and we're doing a whole piece of work around accessible information about screening, particularly bowel screening at the moment, the use of the Mental Capacity Act. Immunisation and vaccination has to remain at the heart of this. This is preventable illnesses. If we have a decent vaccination programme that makes reasonable adjustments. We had a family care group do an audit about whether people felt that they were having reasonable adjustments made at vaccination clinics, for example, so that we could change some of that. Epilepsy is a piece of work we haven't got off the ground yet. I'll mention that later. Diabetes and flash glucose monitoring. We did a whole piece of work around bowel and bladder. Obviously medication and stomp and stamp and trying to make sure people only have the medication they need at the right dose. Cardiovascular disease is our most recently finished project, although it's ongoing, I guess, from that, which Adele's going to talk to you about, and advanced planning. So we have representation. So it's a big group, but it's a really well attended group, and it's a group with a load of energy. And we've written here on the box, but ultimately, if you are passionate about working with people with a learning disability and autistic people, and you care about people's health and wanting to reduce that mortality gap, you would be welcome to attend. Next slide, please. So I've called it a complicated and tricky work plan. We are juggling a huge amount in this group. We report in terms of our governance and where we report into. We report into the prevention board in the integrated care board, and we report into the mental health and learning disability autism board. And then we have a number of different meetings that feed into that. We have obviously the Learning from Lives and Deaths programme, which Adele leads on. We have our Stomp Stamp, we have annual health checks and transitions. So they're strategic meetings that happen anyway that feed into that group. And then for all of the different work streams, we always have to consider reasonable adjustments. How do we personalise our care? What workforce do we need to be able to deliver that? What accessible information do we have? How do we make sure that it's meaningful for people? And are we using the Mental Capacity Act? So they're all the themes that have come from Learning from Lives to Death, and Lives and Deaths, and we think about that in relation to each of the work programmes. And then in terms of, we have lots of ongoing pieces of work, but in terms of the ones that we're currently working on, it's community acquired pneumonia, it's use of advanced planning and the Respect tool, coronary vascular disease and hearts, which is what Adele's going to give you an example of, a stop look care programme, which you might want to mention as well, Adele. Digital flagging that Tom mentioned. Very excited we managed to get some money around tobacco dependency and reducing tobacco dependency, which we're thinking about both for autistic people and people with a learning disability. Haven't got time to talk to you about that. It's a brand new project. We've literally started last week. We think that's a bit of a hidden population of people with a learning disability that are tobacco dependent, and whether they get access to the usual tobacco dependency reduction programmes. And obviously immunisation and vaccinations has to be an ongoing priority. So next slide. it's been much harder to get the work off the ground for autistic people, because obviously we're working on the Learning from the Lives and Deaths programme, and it's only very new since 2022 that we've included autistic people. What we've done so far is we've met with autistic people in Sussex and looked at and heard from them what their priorities are. Suicide prevention is absolutely number one. And we're getting all the information that loud and clear. That's something they are absolutely key as a priority for us. Neuroaffirmative practice, and much more than just the rollout of the Oliver McGowan programme. They see that as just a very early step, and they want to do something much more specific around neuroaffirmative practice and annual health checks for autistic people. They will become more and more of a priority for us as we get that data and as we get more engagement with the autistic population. An aspiration that we have segmented data, so we know what data we're looking at for autistic people, what we're going to be learning from the deaths of people, better use of annual health checks for autistic people, and the use of the reasonable adjustments flag is all the autistic people's priorities. And I've remembered that I've forgotten to say our programme is all age. So children with a learning disability and autistic children are also included in all this work. And in terms of what next, epilepsy has been the hardest to get off the ground, and that's because everybody's involved in epilepsy and nobody wants to take the lead on it. So it's been really hard to gather people together to actually lead a programme of work around epilepsy. It's more happening in children than it is in adults, yet we know it's a key issue for us. Workforce and training and the ongoing rollout of Oliver McGowan, but also other very targeted workforce and training programmes around those specific health conditions I mentioned earlier. Like I've said, a greater focus on children and autistic people, better data. Our data is not good. I think that's a national issue in terms of being able to pull the data that we need around people with a learning disability or autistic people and their health. And as I said, autism, affirmative suicide prevention. We have autistic people involved in all of our suicide prevention work streams that will feed into this board. I know that's a whistle-top tour and I speak very quickly, but I think I'm going to hand over to Adele now.
Thank you, Vicky. Thank you, Vicky. Yes, thank you very much for the invite. My name is Adele. I have lived and worked within the learning disabled community most of my life, and I've worked within it 26 years. And I think I was reflecting earlier on the improvements I have seen in that when I was community nursing 20 years ago, it was fairly common for staff to hide in cupboards when I walked onto a hospital ward. And you just have to think that every hospital's got a learning disability nurse in it now. I think also I've been involved in LEADER since inception, and I'm very fortunate to head up a programme where we listen and relay some very important stories, some very sad stories, but some incredibly happy and positive stories also. But the aspect of the programme that's the most important bit for me is what we do as a result of LEADER. And I'm really excited to share this project with you. Next slide, please. So I can't see the slides moving on. So this, oh yes, thank you. So we are required to write an annual report for the LEADER programme, and I'm hoping some of you know the Action to Learning report. And I think one of the things in Sussex is we were also an early connector around the Core 20+5. Which is the adoption of population health management strategies to reduce health inequalities. Now, the 2021 LEADER annual report identified diseases of the cardiovascular system as the most common cause of death in our learning disabled population. And that was a change because throughout LEADER, respiratory causes of death have been the most common. But with cardiovascular diseases taking the lead in that particular year, that report was presented strategically into the health inequalities arena in Sussex. And some of you may know that actually hypertension surveillance is one of the +5 in that Core 20+5. So what we had is a report that identified Sussex as a bit of an outlier nationally with regards to the age of death of people with a learning disability. They died younger in Sussex than the national LEADER report, and of cardiovascular diseases, which fitted very nicely with that hypertension surveillance. That meant we were actually able to secure some funding. And for those of us working in learning disability services for many years, we're a very creative bunch, and we're very good at taking small bits of money and making a big impact. So securing some funds, we were able to secure a project worker for a year, but we also were able to commission a significant using a significant amount of that money to develop resources, and we were very clear that we wanted those resources developed by people with a learning disability, for people with a learning disability, and around reasonable adjustments for universal services. We've been talking already about the importance of accessibility for our universal services, and cardiovascular disease, as you know, is the most common cause of death for the general population. We'd also checked to see what was around with regards to accessible resources, and it was quite limited. What we also know from our identification of deterioration work stream and work that I've done over the years is that actually services supporting people with a learning disability are absolutely expert in the language and vocabulary of personalisation, inclusion, rights and choice. But sometimes that vocabulary, and particularly health literacy amongst the workforce, is not as available. And that's certainly no criticism, because I think, you know, we are the pioneers in so much. But when we are developing resources for people with a learning disability, I'm also always thinking about education and training into the workforce. So within the project, we wanted to look at what we had, and actually that is, what are our universal services? What prevention services do we have there from our local authority wellbeing hubs and our social prescribing? And actually, what do we know about people with a learning disability accessing them? And we know that they don't actually collect that data. As I said, we wanted a suite of resources for people with a learning disability by people with a learning disability, and we wanted people with a learning disability to train our social care workforce, but also our universal services workforce, those people providing that day-to-day lifestyle management for cardiovascular disease prevention and management. We wanted to improve our data. I'm a learning disabilities nurse. I have said for many years I'm allergic to data. However, it is absolutely fundamental in how we develop services going forward. I've talked a bit about the training, and we're now in the position where we're promoting and sharing our resources. And SPECS is the Sussex platform for education, which I can put the link to in later. Next slide, please. This is some of the feedback from the training. So we did 3 face-to-face training for adult social care, and we did 1 large face-to-face training, no, online training for universal services. We got 74 people at the training for the universal services. So that's wellbeing services, social prescribers, district and boroughs, and all sorts of different providers. So I think the feedback that we got is that the best bit was to hear from people with a learning disability themselves. We had people talking about their experience of having an annual health check. Actually, how does it feel to have your blood pressure taken? You know, all of that stuff, because you'd be surprised how many leader reviews I've undertaken where somebody is on anti-hypertensive, so medication to manage their blood pressure, but I'm not seeing regular blood pressure checks, and I'm saying won't have blood pressure checked, won't have blood pressure checked. Now, for those of us that have worked with people that don't like having things done to them, actually one of the most useful tools we've got is mirroring. And we talk about that with oral hygiene as well. So I know that if I want to support someone to have their blood pressure checked, I'm quite happy for them to see me do mine first. And it's those very practical things like that that people responded to. Next slide, please. So I think now we are talking about sustainability, and you know, like I say, it's a time limited amount for the resource that we had, but we have got all of the resources are available on our website. From the Health Inequalities Programme Board, we're looking at our website and making it more accessible, but we are putting all of our resources up there. Tom, we do have the Leader National Resource Bank, and I think we are really looking forward to getting some of our resources on there. It's a great resource for those of you that haven't seen it. We have already got Sussex resources that we've already undertaken for cancer screening going up there, so I'll be applying for the resources to go up there. On Sunday, we've got our launch event, and actually, my day is done. We have got our local learning disabled influencer and celebrity coming to that event, and we're going to show our films. And I think I attended the opening night of the Oscar Bright Film Festival, and it was hilarious to go up and meet the stars of the films, people with a learning disability, and say, oh yeah, I wrote the scripts. That's not something that I ever thought I would ever do when I was in nursing school, but writing those scripts and developing those scripts with a cohort of people with a learning disability was some of the most rewarding work I've ever done. We've talked about the Learning Disability Annual Health Check. We have an annual health check steering group. This will be presented. It's been presented to the ICB staff briefing. It will go out to our primary care briefings also, because we want to see better hypertension prevention and surveillance within as part of that annual health check and coming out of our health action planning. The data, unsurprisingly, has been the hardest nut to crack. And as Vicky alluded to, we've been successful in securing further funds around tobacco dependency. So we will continue work with the data set. But what's been interesting about the data set and the reach across and the beauty of an ICS is that it was a self-advocacy organisation that undertook the development of the resources and the films. But getting the ear of our data colleagues working in other organisations and them actually saying, oh yeah, this is relevant in other health inequalities work, or we need to think about people with a learning disability in this other piece of work. And that for me has been the beauty of the ICS, to kind of plant those seeds across a whole range of systems and services, and bringing all of those systems and services together for one product, particularly the films. We have talked about the lag, so we're not going to show the film now, but I would like to ask for a pledge that people watch the films. They are an incredible education resource. There may be some services out there that are still doing Film Friday with your bowl of popcorn. I'd love people to sit down and do a health film Friday.
Adele,
and I've talked about the achievements, so here we go. I'll stop talking.
Lovely. Adele, thank you so much. And yeah, we will share the details of the film at the end. So much there, but just really to Tom's point at the beginning, when Tom started us off and talked about how things have improved and some of the positive examples of good practice, what a fantastic range of different interested parties you've brought together there to form this coalition of the willing, and you've got what you described as a somewhat unwieldy group, but well attended and loads of energy. And I think when you showed the slide about the complex structures, we shouldn't underestimate how difficult it is to bring such a wide range of people together. Again, also covering such a wide range of health issues and topics. So thank you so much for that. I'm going to move us on now to our system example number 2. We're going to hear from Paul McKay, who's the Chief Executive at the Wilf Ward Family Trust, which is an ARC member. The Trust supports people with learning disabilities, including people with profound and multiple learning disabilities across Yorkshire. And Paul's going to share a case study with us that, again, talks about joint working, but how this can tackle system changes and deliver person-centred care. Over to you, Paul.
Thank you, Clive. Yeah, I very much appreciate being invited to talk today. It's always helpful to follow people more expert than myself, so they've answered most of the questions that I would have been putting to you. But I think where the system isn't quite working for us yet is when we access emergency and acute hospital systems. And that is something that causes not only the individuals we support distress, but in many cases their relatives, and also importantly to the staff that support them. And if we can move to the first slide, there's some examples of things that now have come to our attention in the last few weeks and months that just demonstrate where accessing the acute system can go wrong. And picking up on what Tom said, it's very much about leadership, and it's very much about attitude, I believe, and seeing people who have learning disabilities as having that need for more approach to support them and less approach to do the task. Because it seems every time something is going wrong, when anyone we support enters into the acute system, is because they're treated on their condition rather than treated as a person first. And if we swing back into what Amelia, Bev, Stuart, Matt and David have said, is actually that fundamental right for someone to be treated as a person that seems to be the bit that causes really great healthcare to move into often quite catastrophic outcomes. Some work that we are doing at the minute is with NHS England and ARC, working on a particular case with a gentleman in his 80s who actually at one stage was confronted by 5 people firing questions at him all at once, and he got upset and distressed, and he was the one that was seen as being the problematic person in the room, when actually our staff had to step in and go, he can understand, he has capacity, but he only has the capability to deal with one person at a time. And whenever that right was respected, and whenever he was given time to consider and think what his options were and what was happening to him and the consequences of that, his behaviour changed from one that was seen as problematic to one that was very cooperative, and one that actually got him the treatment at that time that was best for his needs. But if we can move to the next slide, it doesn't always go badly wrong, and actually there's just a little clue to that, which time and time again we all as practitioners know. If you recognise and see the person first, if you talk to them, if, as Adele says, you do that mirroring, then that actually can really take someone through into a very different experience of where they are and how successful the treatment outcomes are. It really is something that we have seen time and time again. Certainly when the liaison nurse becomes involved, absolutely changes circumstances. But when you have nurses or doctors or even cleaners, ward staff, administrators who talk to that person, are interested in them, and actually listen to either what they're saying or what is included in the hospital passport, makes a fundamental difference and changes things completely. Next slide, please. So there are a number of things that can help to change this, but fundamentally we need to have recognition that the social care staff sometimes can be not a hindrance but more of a help. And taking back what we heard from Amelia, Bev, Stuart and Matt, now actually don't talk to the staff first, talk to the person first, because even though there may be issues of communication, many of the people that we work with, despite their needs, still have a vast vocabulary and understanding and ability to communicate back. And that should always be the starting principle. I do think that hospital passports are used by those who know how to use them, but are seen as a task and a chore by those who don't understand the benefit of them. And we've seen the shocking figures that indicate that actually it's not that well understood outside the system, never mind within it. And just a challenge that I put out there, is deprivation of liberty and mental capacity really understood? Because time and time again, that seems to be something that we can come back to as a problem. Next slide, please. So one of the things that has happened recently as well is we did have an incident and we raised it internally with the hospital, raised it with safeguarding. Everything went quiet. But what happened then was we had a reach out from the quality improvement team within the hospital, and actually them sitting down, impartially listening to what went wrong, trying to work out how to do things differently, dedicating some time to listen to those involved changed the feelings that were left behind. And I think that's a really important lesson that we need to learn too. At the minute, I hear time and time again that my staff are worried when someone goes in an ambulance or when someone goes to hospital, because often they can't be there. And that means that communication doesn't happen as well as it could. And we hear stories of people being left alone and probably not hydrated and probably not fed for quite a considerable time. But if we can work with the system and work with the teams to look at why that's happened and understand how the next time it can change, then actually we're very willing to do that. And I think that's the message that we have to leave, which is that social care is part of the system, wants to be more part of the system, and actually the best experts in social care are often the people who've been receiving it for the past 10, 20, 30, 40, 50 years. And we wouldn't in any other profession ignore that level of expertise. So we might have to sit and question ourselves as to why we're ignoring that expertise whenever someone comes into a hospital, which is often a scary place for scary reasons. But again, coming back to what was said earlier, we congratulate ourselves on having people leave long stay institutions after considerable periods of time. What we forget is that they may still have memories of being in that system. And it's really vitally important that we don't miss that compassion that's needed and that recognition that just because they've lived in supported housing or in registered care for 30 years, they don't associate hospital with very, very negative memories and experiences. And it's that compassion that's needed in our sector and working with people to understand how we do that better. So 3 takeaways I would say, which again, I think have been said: slow the pace down, give people time to understand and communicate the way they can. And I believe that's already been said. Personalize the approach. It's different with everyone else. Learning disability doesn't mean that tens of thousands of people are all the same. Every person is different, and a learning disability is just part of who they are, not what they are. And I think what we also have to just look at then is we're all leaders in the sector, so let's lead by example. And the next time we see someone with a learning disability, see the person and not the condition. Thank you.
Thank you, Paul. Really powerful insights from a provider with the experience and staff who have that experience. Fantastic presentations from both of our system presenters, and we're going to just move now straight into Tom is going to take us through the next section, which we'll look at is a panel discussion, and I'll hand over to you now, Tom.
Thank you, Clive, and what an excellent session so far. And I'll provide some observations in a few moments. I'll go straight into the panel, and I just want to welcome Hazel Summers, Director of Improvement and Partners in Care and Health at the LGA. Welcome, Hazel. And David Holmes, Chairman for Peak 15 Support. What we'll do is, if I'll just ask Hazel and David just to give an overview of obviously where they come from, but their perspective of the challenges, the opportunities around for us now in terms of health inequalities, and then we'll open up for some questions. Hazel, are you with us? Are you able to go first?
Yeah, thanks very much, Tom, and what an excellent session it's been so far. Really powerful listening to what people have to say. So I'm Hazel Summers, as Tom said, Director of Adult Social Care Improvement in Partners in Care and Health, and we're a partnership of ADAS, that's the Association of Directors of Adult Social Services, and the Local Government Association, both of which are member organisations. The LGA is a member organisations of all councils in England, and ADAS is a membership organisation of all the DASs, Directors of Adult Social Services. I was previously a DAS in Manchester City Council. I just want to talk a little bit about some of the work we've been doing around peer reviews. And for those of you who don't know what a peer review is that a peer review offers an in-depth look at services and provides a critical friend look, and it's from people who have expertise in that area. So they could be clinicians, they could be support workers, they could be nurses, they could be anything that is in the area that we're looking at. And we have trained up 5 people with lived experience to do all of those peer reviews with us, where we have looked across health systems to look at where we can see where their challenges are, but also what we are seeing is an enormous amount of good practice. And I think the biggest challenge for us is how we share that great practice. Like we've just heard from Sussex, for example, which is one of the areas of good practice. We had identified some of that great work that was going on there, really. Just want to say, though, what people with Trevor and Callum, who are people with lived experience, have as peer reviewers, they've said about why we do them. And we want to find out how our local partners are doing to make sure that all people with a learning disability and autistic people live a perfectly ordinary life, to live in an ordinary house, on an ordinary street, have relationships, have work and to have fun. In this context as well, to feel seen, heard and respected, and to be a valued member of society. Exactly the same things as everybody else, really. By the end of June, we will have completed 8 peer reviews, and it was as a result of these reviews, we worked with individual councils and ICBs to develop autism partnership boards, early support offer for autistic people to prevent them from going in hospital. And that is one of our key challenges, I think, is around how do we stop people ending up in hospital in the first place, I think. Some work around approaches to co-production, approach to care education and treatment reviews, dynamic support registers and health checks. We've also done quite a lot on developing guidance on closed cultures and various other areas of work, but I'm not going to talk about those at the moment. We have seen some really brilliant practice, and again, it's the how do we scale up some of the really great stuff. I'm going to concentrate on that more than the challenges, Tom, I think. So we already heard today about David was provided with support to book, and people having a book, but also supported to book and attend at their annual health checks. Enable individuals to attend immunisation and screening appointments. There's some really great work has happened on co-production in some ICS partnerships. So to co-produce ways to improve access to services. So Stockport, for instance, have got through their autism strategy. And I think we've looked at hearing from people supported by services about what's not working, and to co-design the solutions to barriers and blockages, to go back to our West Midlands colleagues about how important that is. It's also kind of access, you may be aware, again through ICSs and through local authority. Councils commission a range of public health services, and some of these are commissioned to specifically meet the needs of people with learning disabilities and autistic people. For example, in Cambridgeshire, sexual health services have been adapted for people with a learning disability. In West Sussex, specialist health visitors working with families with neurodivergent children, and weight management services specifically for people with learning disabilities in Gloucester. Also, I think we need to be thinking, and I know this is feels like it's concentrated on the health services, but if you think about the wider determinants of health, we've seen some really great examples of support people to gain and retain employment, including supported internships, and by offering employment opportunities. And also really thinking about how people's income can be maximised, etc. Where I think there are some good opportunities around the Oliver McGowan mandatory training, be key to ensure that staff are knowledgeable about people with learning disability and autistic people. I really take the point about seeing if people have symptoms and not seeing past the fact that they have a learning disability. I think that's really, really important. CQC assessments of adult social care and the forthcoming ICS systems include requirements to demonstrate how inequalities are being addressed for different groups, and that will include autistic people and people with learning disability. Where I do think we need a lot more work is really thinking about the economic case for reducing inequalities. There's more work to be done in health and social care to articulate the economic cost of inequalities. For example, the cost of avoidable admissions. higher costs of late cancer treatments, lower employment rates. And finally, I think there's something here about where we're thinking about how we work with digital. As more services are digitalised, it's important that these are built with autistic people and people with learning disabilities in mind to help them get greater access to services rather than becoming a further barrier. So those are just some of my reflections and some of the work that we've done, Tom.
Thank you, Hazel, and we'll have an opportunity to test you on some of those in a moment, I'm guessing. David, welcome.
Thank you, Tom. As Hazel did, I'd just like to reflect on what a great call this is, and you know, you're talking about subjects I don't feel particularly close to, or have great insight about, but really encouraged that there's so much great work going on at a system level to address these issues. I'm a provider. I own a company called Peak 15. I own the Butterfly Project. We provide a range of services in West Sussex and Surrey. I've been doing it for 27 years. I'm really passionate about what I do. I think we do it reasonably well in the context in which we exist. I think Clive invited me onto the call because of his knowledge of two pieces of work that I'm engaged in at the moment. So the first is a piece of work called Reinventing Social Care, which is a provider-led initiative to shape government policy in all aspects of social care. It's a programme that we describe as being a programme of 1,000 nudges, and it's taken us into some great conversations with politicians and senior people at the department, and DASAs and representative organisations and others, and we're soon to produce a report. This is our report. It's different from every other report. It's in comic book format. It's the project of 3 years of random conversations by a bunch of providers that come at it with a good heart and a real passion about social care. And I will put an email address in the chat if that's okay. If you want a copy of our report, I'd love to send it to you. The second piece of work I've been engaged in is something called Big Life Adventure, which is a piece of work that is driven by my organisation, Peak 15, something we've been working on a co-production basis for 5 years, and it's about empowering people with learning disabilities to take control over their own lives. It has a piece of user-owned software at the heart. I think it's going to be really transformational for people with learning disabilities. I mentioned both of these pieces of work because I think at their heart lies a conclusion that there's a better model of social care than the current model, and that the future model moves away from the medical model from whence social care came, and it's a social and developmental model which seeks to close the gap between the way that people with learning disabilities and autism live and other systems in all areas of their life, including health. It's a model where people live more independently, but with greater connectivity and richer and more varied support structures, including the application of innovative user-owned technology. And I think it speaks to Hazel's point about the wider determinants of health. I don't have the statistics and I don't know if the research exists, but I'm sure elements of it do, but I'm prepared to wager that people who live with a loved one have better health outcomes than people that don't. And yet we know that in wider society, 70% of people live with a loved one. For people with learning disabilities and autism, I think the figure's 3%. You know, so if we could kind of shift that up a bit and somehow support people to find love, you know, and live with loved ones, and that they would live healthier lives, and that would take pressure off the NHS. I'm sure that's the same of people in employment. I'm sure it's the same of people that live in a home of their own. I'm sure it's the same with lots of different aspects of life. So if we can produce a better model of social care, then we will support people to secure better health outcomes. That seems really logical to me. Of course, the question is, what does that look like and how do you achieve it? And that's no mean feat. And there's quite a lot of that wrapped up in this report. That model for me is a model where people are supported by people who are teachers and enablers rather than adult sitters. It's a model where we are paying people better to deliver fewer hours of support. Actually, it's a model in which I would consider that everyone wins. And I think that, you know, I can talk for a long time about what I think the drivers of that model should be, but for me there's 2 or 3 that feel really important. So I just want to mention those very briefly. The first is consumer sovereignty. So we've done quite a lot over the last 10, 15, 20 years, and those of you that have been around as long as me on the call will remember the Care Act, will remember In Control initiatives, will remember all the stuff that we've done to try and put people at the heart of their social care journey. My view is that that's not been wholly successful, and that there's much more that we can do, that we can support people to have a statement of aspiration at the very outset of their social care journey that sets out their strengths and their aspirations for their journey, that talks about how they want that journey to go, that we can give them better independent support at the outset of that journey when they're setting off on that journey at their very lowest point, and that we can address the kind of the horrible paternalistic processes that still exist within our systems. You know, imagine being assessed by several providers one day after another. Imagine sitting in a review where people are talking about your most personal details. Some of these processes are dehumanizing, and I think we should be ashamed of them. The second thing I would say is around commissioning. So in our team in Reinventing Social Care, which is 12 providers from across the country, we tried to come up with good examples of commissioning, and we came up with about 2. And that feels tragic to me when commissioning is such an important process in our system. So if consumer sovereignty is the pull of quality through our system, for me, commissioning is what needs to push that quality. And yet what we see, particularly when times are tough, is commissioners reverting to old style Marks and Spencer's type commissioning practices, which are pushing down on unit cost. Whereas what we want to see is really creative commissioning, which is focusing on outcomes. You know, what I want our commissioners to do at Peak 15 is not give me £22 an hour or whatever they give me. What I want them to give me is £40,000 a year, and I want to be able to spend that not just on hours of care and support. I want to be able to spend it on Glastonbury tickets and driving lessons. You know, that's what I want to be able to spend it on. And that kind of brings me to the bit in the middle, the bit in the middle, the delivery model. And clearly the delivery model for me has to be about supporting people to articulate big long-term dreams and use those structures, the creative structures, to support them to achieve those dreams. And in doing so, that supports people to live richer lives, supports people to develop skills, supports people to develop relationships, to find love, and ultimately to live with less support. I'll give you one final concrete example of that. So I'm lucky enough to go to Glastonbury every year, supporting a bunch of guys with learning disabilities to clean toilets. It's not for the faint-hearted, let me tell you, but we have an absolute blast. And the first time we did it, we took half a dozen people, and we did it with 6 paid support staff. This year we're taking 10 people, and we're doing it with 2 paid support staff and a whole bunch of volunteers. For me, that points to a model of the future. You know, that's people expanding their social capital, that's people developing relationships, that's delivering a model of social care which requires less from the public purse, but actually enhances the lives of people. I'll stop now. I could go on for a while, but I should stop now. I do apologise if I feel like I'm on my soapbox here. I need to get
David, don't apologise, and I think the example you gave just at the end is really, really helpful. About when we talk about a better model, we often wonder what does that mean. We would say the same for the health service. We would say for the same, and the people who are autistic and with those with a learning disability would often say to us, what you offer us now doesn't work. So a really good example, and Glastonbury might be one of the extremes, but thank you very much. Thank you as well, Hazel, and the peer reviews have taught us a hell of a lot about what's good and what really works, and leadership is one of them that we keep talking about. I'm going to hand over to Victoria. Victoria's got a couple of questions. We've got a few minutes for that.
Yes,
Victoria,
we do, Tom. Thank you. We've had lots of things come in. So I'm suggesting that maybe we take the first question, which was a bit earlier, about the reasonable adjustments flag. So this would be for Vicky, the other one. And the comment is, if there are if people are, Vicky thinks that it will help reduce the inequalities in how social care providers can engage to ensure that the reasonable adjustments digital flag is rolled out across the whole sector.
So we're on a really, really early stage of rollout of this. We are at the point where we are about to share information about the reasonable adjustments of flag far and wide, what we should expect to see on that flag, what you can include, and it's going to be a massive profile raising around this reasonable adjustments flag. That's where we're at with Sussex. It's everybody's business. Everybody needs to know about it. It's not just for people with a learning disability or autistic people. It's for anybody that needs a reasonable adjustment around their healthcare, and it could make a real difference. It's been something we've been asking for so long. So I guess I would be thinking we need to make that information about the reasonable adjustments flag or the digital flag really easy for people to understand, give some examples of the sorts of concrete things you can do. In Sussex, we've got a really nice thing about reasonable adjustments you can ask for at your annual health check. We might use, and that's been co-produced and has come from people that use it. We'll probably use something like that with the population in Sussex to say these are the sorts of things you could ask for to have on your flag. But at the moment, it's a real news camp. This is a good news, big news campaign. It could make a real difference. But it's everybody's business, the reasonable adjustments flag. That would be my summary for that.
Thank you. We've got a couple of questions to the panel. Anybody could take these. I think that there's a really interesting point around transition and family care arrangements. And actually for those individuals that might be within foster care services, that there are sort of difficulties in making those transitional arrangements work well, having people that have the right to represent those people with a learning disability or autism in their hospital visits, and how we make this transitional arrangement more effective and work in partnership across social care and health services and local authority. So Tom, maybe a starter for you and a follow on from David.
Well, thank you. Just check it. Thanks, Victoria. It was interesting. I was just reading the question that was earlier about the person who was approaching hospital and didn't feel supported, and there is much more we can do there. And it's interesting. 71% of people didn't know or know anything about the passport, which is shocking. So there is quite a lot that we need to do around hearts and minds. I think we need to take away this concept of what people think that reasonable adjustments are really, really difficult things. Most people tell us they're about time, respect, having prepared your work, having read, having thinking about what you need to do and thinking ahead. And we need to do a lot of work with our acute trust colleagues, our primary care colleagues to do that. That's the element of that I would pick up, and that's what we got to keep driving with. We're not talking about new services. There's a lot of conversation in this about respect, treating people with dignity, and everybody's entitled to a common service local to them. I'm not quite sure I'm picking up everything, Victoria, but that's the element that I've heard.
Yeah, no, that's really great. And there is a secondary question, which is about inconsistency of approach across different ICBs. So how do we get that working more effectively, specifically for care providers that might operate in numerous ICBs?
Who are you asking?
Probably you, Tom, if you're ready to answer that, but Hazel.
I think one of the real benefits and things we're excited about is the ability for ICBs, and Vicky, really showed that, about to really think about their local population and do what matters for those. That will create a little bit of inconsistency, not in terms of outcomes, but in terms of the way things are done. But the most important part of this, I think, is they listen to their community. And when we think about we're doing something well, I'm struck by the comments earlier about the research from the West Midlands group. But people think we do it well, but actually when it goes to the people that matter, they're not seeing it that way. So I think the differences between ICBs for me is not that important. It's about, are they meeting the needs of the local population, and does it really matter for those people? So, Vicky, I'd love to come and visit your services, but I'm going to be asking you, like everywhere else, if we spoke to the population, what would they say? I'll stop there and I'll let other colleagues answer.
So Tom, I just want to come in really to think about the ICBs and how they might work. And the critical thing is that within each ICB there are a number of councils. And we recognise that, but I was part of Greater Manchester Devolution, and the big area around that was absolutely not made to say, no, you will get different approaches because actually you're dealing with your different populations. And actually in Manchester, where I lived, you could be living in North Manchester and that population would be very different to South Manchester in terms of what you are. I think that there is still some room for ICBs to really, not just local authorities, but for ICBs to really be talking to their social care providers. We have heard some wonderful examples lately about where social care providers are dealing with people or working alongside people with incredibly complex needs. Providers have some wonderful ideas about how you can take that forward and be different. As David said, do things differently. And actually, there's a lot of benefit, I think, from ICBs talking to social care providers, people who use services, obviously, and also to their local authorities to really try to come together about how you can get a better outcomes for that local population.
Can I add very briefly? So I would say that just a couple of very quick points. One is that picking up on Hazel's points, I think those conversations between ICB and providers have started now, but have been quite late to start. So I think there was a failure to cement representation of the provider community in the ICB structure at the outset, and it feels like we've been playing catch up with that. I would reflect back on an earlier comment about how far we've come, actually, that hospitals now do have LD liaison nurses, and it used to be the case when one of the people that we supported went into hospital, we used to have to put people in to support them because it was the right thing to do, irrespective of funding. And it feels like that we used to have to do that through necessity, whereas these days it feels like we get to hospital and there is someone to liaise with, and we are able to work out a joint approach, and that serves the people that we support better than once it would have done.
Thank you.
Can I just say, oh, sorry.
Go ahead, sorry.
I just wanted to say one really basic point from our experience in Sussex is that, and it relates to the ICBs doing different things, where you know that there's a real priority area. Let's take, I know, bowel and bladder care. We knew it was a big issue. We knew people dying from constipation was a massive issue. We brought together everybody that was working in bowel and bladder care in the ICB. We found the bowel and bladder nurses. We brought them together for a first meeting. We said, what are we going to do about this? And that hadn't happened before. And we've done the same with all these different areas. And then we work with our providers through our partnership boards, our family carers, to bring that work together. But it started with just somebody taking the initiative to say, let's bring these people together to think about the impact of people. It's not that difficult, but you need somebody to lead it and bring people together. So the how you do it in the ICBs, I don't think matters too much, but the issue is bringing people together around a common area that there are a load of people working in coronary vascular disease, a load of people working in tobacco dependency, but they're not necessarily all coming together in an ICB, and they're not all coming together to think about what does this mean for autistic people and people with learning disability. So just bring people together, and then I think things make a real difference. That's my learning from what we're doing in Sussex.
Thank you, Vicky. I'm conscious of time. We're just coming up to the point where we're bringing our session to a close. I want to thank all of our contributors. We've heard from such a range of different people with an interest in helping us to reduce health inequalities for people with a learning disability and autistic people. We've also had some very personal stories shared in the chat, so I do want to say thank you to folk for sharing those. We will be issuing some resources and reference documents following the session, which we hope will answer some of the questions we didn't quite get to today. I want to close by just focusing on a few areas where we think we may have some opportunities. I think today has shown very clearly how much we have achieved in some ways along the journey of the last 20 years, and what has been achieved in positive areas where we've brought together all different parts of the system to work together, but there's more to do. One of the things I wanted to highlight is the new Procurement Act, which I think does start to move us away from the idea of competition, and it speaks a little bit to David's point about consumer sovereignty and markets. So we've got this new act which helps us move more towards collaboration. I see that as a very clear opportunity. There's a clear opportunity for health and social care commissioners to work together within integrated care systems to help address the changing needs of the population. And there's also a clear opportunity to use the relationships that we have with learning disability provider teams and family carers. The final thing I wanted to touch on was there's some clear opportunities coming through with digital solutions and potentially AI as well. So the West Midlands Advocacy Network clearly using quite a lot of technology in their research work. So Thank you to everybody that's contributed today. It's been a fantastic session, and I've thoroughly enjoyed it. I hope everybody else has too. And we'll share all of the details of the content of the slides, and we'll share the resource documents with everyone that attended. Thank you, everybody.